Hey, thank you for joining us for an episode of the Medicine Mentors, where we interview leading physicians on the best tips, lessons, and pathways to mastery for aspiring physicians. Our mission is to learn from top mentors the most effective paths to mastery and fulfillment in medicine and to spread their knowledge. For this episode, we are joined by Dr. Viswanath Vasudevan, who is the Program Director of Internal Medicine and Medical Director of the Sleep Center at the Brooklyn Hospital Center. Dr. Vasudevan's expertise on clinical reasoning really shines through in this interview. His perspective reveals some of the key systemic issues that physicians are facing in their training and clinical contexts. And he also gives us the medicine for how to personally adapt to avoid the pitfalls and be the most effective physicians possible. Thank you for being a part of this quest for knowledge and betterment in medicine. We've all heard you talk about self-audit and self-directed learning, and also heard billionaires like, there's a book that recently Mr. Ray Dalio released, and he said that pain plus reflection leads to progress. Where did you come upon these concepts at such an early age, and how did you put them into practice?
You learn more in life by introspection and self-reflection. I think it is an ACGME core competency which I try to impart to our residents, and that is called practice-based learning improvement. We learn in the context of patient care, and residency training program is all about applying that content of knowledge in the context of patient care. What I call is an apprenticeship. You learn the most from our patient, and I think the Brooklyn Hospital is truly blessed to see a diverse patient population with a very diverse pathology. Obviously, given the healthcare economics in this country, one need to be cost effective because we drive the healthcare expenditure. So the quality is important for patient satisfaction, patient safety is important, and it is said that 1/3 of the healthcare expenditures are being wasted. It is unhelpful and harmful to the patient. So I think the cost consideration really need to be built into the residency curriculum. So for you to be a complete physician, because we are in control of healthcare expenditures, I think we need to take a leadership role in that.
You also mentioned that learning happens in the context of patient care, and you've talked about how we learn by doing and by teaching. How do you think we as residents should go about applying this in our daily career in the hospital?
I think the residents have plenty of opportunities. All it takes is initiative and motivation to do it. I believe 80% of the education in graduate medical education occurs in the context of patient care or the patient's bedside. Even though we put a lot of emphasis on classroom education. Classroom education is just to supplement your educational knowledge. But the real challenge is applying it in a given patient. Because when you see a patient, the patient doesn't read the textbook and come to you. Textbook describes single system disease. But in real life, you see patients with multiple system disease. And you need to tease it apart. And that requires experience, knowledge. For example, the surgeons learn by doing the procedure over and over again. I think the intern is we need to practice that skill. Clinical reasoning, critical thinking, complex reasoning, and develop a problem-solving skills. Even though we put a lot of emphasis on artificial intelligence, my fear is the artificial intelligence will take away our innate intelligence for problem-solving. I don't think Dr. Watson can help you make a diagnosis or help guide management, because medicine is not A plus B. Medicine is very, very complex. You have to bring in all your experience to bear on the patient's outcome.
Our job is to think, and it's not just to write the routine orders, and that's what we get paid for, and that's our job profile, is to think and to assimilate all of the data and then to apply our minds.
Just expanding on that, recently there was an article in Annals of Internal Medicine, and it was titled Clinical Reasoning, How to Teach Clinical Reasoning to Our Residents. I was just curious to know where that article came from. There was an article from Harvard Medical School, and they blame our current healthcare delivery model, which doesn't allow you to think and order tests in a sequential fashion. I think the focus now is to do all the studies on day one the test will show something and go off in a tangent. So patient care changes hands from one physician to another physician. And that kind of independent thinking is kind of lost. People just pass on information from one physician and they don't take ownership. And I think part of the problem is the healthcare delivery system, which rushes the physicians, and they have to get the patient in and out. So it doesn't leave any room for critical thinking. And all the tests are done on day one. It should be done in a sequential based on the results of those initial studies.
We were talking about cost, and a lot of us, unless it's coming out of our own pocket, we don't worry this is costing this amount of dollars as a doctor to a patient or as a patient. But we've seen that you had a passion for this. Where does that passion come from that you have? Where does that come from?
I think it's very important not only for the physician, but the taxpayers are paying the burden of these unsustainable healthcare expenditures. I think this is a problem which is unique to America. It is not seen in the rest of the world. I think the third-party payment system encourages this reckless spending. I think all of us are misinformed that somebody else is paying for it and the patient is not paying for it. All we need to do is change roles. I have been a patient. I've been hurt deep in my pocket. Because when you order a test to a patient, the consumer, the patient, doesn't really know the value of it and is asked to purchase a service without knowing the value of it. And a lot of us believe is that somebody else is paying for it and not the paying for it. In fact, the number one cause of personal bankruptcy in America is health related. I think we physicians should be cognizant of that. At the end of the day, the patient goes home, they will get a sticker shock. And the patients are going to be very, very unhappy. So it is not something, the quality and safety, the cost is equally important. The American College of Physicians implemented a curriculum in 2011 about high-value care. How to deal with the patients who is requesting more and more expensive studies. Unfortunately, 8 long years have gone by and we haven't really implemented that. I think I blame the faculty equally. I think we are also part of the problem. I think we need to be more aware and raise the level of awareness. For example, you walk in ICU, tests are ordered at the drop of a hat, without thinking about the value, without thinking about the yield. You want to rule out the unlikely possibility that this is not there, as if there are no consequence to that. I think we need to instill that value in the resident. Whatever they learn in residency, they will practice. So our culture should inculcate good habits.
Also about cost, when a lot of us, especially a lot of the more senior people, do some testing, a lot of the time the thing in their mind is something like medical legal. So how do you reconcile and how do you manage that risk?
That is a huge problem. Many physicians blame the defensive medicine why they are ordering too many diagnostic studies. But at the end of the day, there are consequences for doing an unnecessary diagnostic study. Number one, it is not without risk. Sometimes it will reveal something and you start chasing it on a tangent. Just to give an example, they were talking about lung cancer screening. When it was done in a study environment, it decreased the mortality by 20%. But you take it to the real world, the situation is very, very different. People are doing unnecessary diagnostic workup, and some of them are associated with complications. So now people are putting more and more emphasis on shared decision making, that we should be explaining to the patient ahead of time. There are certain risks involved. It could be a psychological risk. Your CAT scan may show a spot in the lung, and you may have to leave for 2 years that you may have a cancer in the lung. Sometimes the physician may have to stick a needle in your chest, and that may create a pneumothorax. So the downside effect is significant. So we are not excluding a treatable, reversible disease, but you may come up with some incidentaloma and start chasing is with the downstream expenses and discomfort to the patient.
Sir, you've been on the front lines of residency since you were a resident more than 3 decades ago, and now as the head of the program. What changes do you see in the times when you were a resident to today?
I will share with you when I was a resident in late 70s, we worked long hours, but there was a continuity of care. Now because of working for long hours, the physician may be impaired, they make medical errors, So the physicians work for short hours, but the downside is there are way too many transition of care and handoff. That is not conducive to learning. If you have to learn about the patient, you require a longitudinal follow-up over a period of time. The typical example I cite the residents, you are playing a soccer game. You are holding onto the ball for a few seconds, then you kick the ball to another provider. No one is taking ownership. But that said, the residents are not working long hours. They are more rested. There are fewer errors. ACGME conducted a recent study looking at the old system versus the new system, what is called I-Compare study. And they looked at outcome in terms of Medicare recipients' fatality, and there was really no difference. Other good things have happened. The residents have more say in it, which I welcome, because ultimately they are the consumers. I think we need to get their feedback. And the resident survey is very, very important, because we may think that we are doing a very good job, and they may have a lot of grievances and concerns, and they can express their views for opportunities for improvement. The other good thing is ACGME is putting a lot of emphasis on physician wellness, because physicians typically work long hours, up to 80 hours a week. And ACGME cautions when you join a residency training program, it may require sacrifice of personal life. And you may have a tough time juggling personal life and professional life. So burnout, depression, God forbid, suicide, these are a common occurrence. And we should recognize that and take some remedial action. So there are good things which have happened over a period of time. I would say overall, the residency training program is better structured. There is greater accountability. There is a greater oversight from residency training program. I think the core competencies takes the focus from process to the outcome. And the 6 core competencies really are very, very comprehensive. Probably not well understood by many of us. We need to be more educated, what is called faculty development. So we can educate the residents. We can give them a feedback on that. So I think it's better structured. I think they are going in the right direction.
Having worked with thousands of students, residents, and fellows for over 35 years, is there a common set of traits or attitudes that you find in the most successful residents?
The most important characteristics is taking on the initiative to do things on their own. Motivation, commitment to lifelong learning, commitment to personal and professional development, good work ethics, being courteous to your colleagues, respectful with your patients. I think all these things are important traits. For someone to be successful either in their academic career or professional career, I think you need to have all these traits.
You mentioned how adaptability and being able to take advantage of opportunities was key to your career at various points. In this apprenticeship that we have, what are some of the things we can do so that we are better prepared to be adaptable and to take advantage of those opportunities when they present?
When you say adaptability is all about flexibility, Donald Rumsfeld, President Bush Defense Secretary, made a very famous quote. You have to fight with what you have and not you wish to have. So a lot of residents may wish they have better mentors, but we have to deal within the confines of what we have. And even though we assign a mentor to all the mentees or the residents as the initial step, someone has a passion to do something, they can select their mentors. And the mentee-mentee relationship to me is like a two-way street. The mentee has to express interest with the mentors and meet them on a more frequent. Obviously, the mentors should be more engaged in mentee. I think this is something which we struggle. I think many of these institutions, they struggle. I think it is a two-way street to maximize the benefit from that.
In the past, do you feel that by circumstance or by nature, this teacher-student relationship was somewhat closer or more cohesive than it's kind of become in today's age?
When you say the past, previously this program is something, we didn't have a formal mentor-mentee program in the past. This is something which has been instituted recently, and some of it comes from oversight and regulatory agencies. In fact, many of our residents are hesitant to tie up and pair with the mentees. So this is something which we need to enforce, because we should not play a blame game that the mentor didn't take interest in me, he didn't provide help in navigating the research project. So it's a joint venture, and we should maximize the learning experience from what we have. The mentees have the ability to tie up with the mentors in their area of special interest. That option is always open.
If you had to tell one thing about patient care to young residents like myself to remember when we're seeing patients, what would that one thing about that be?
No, I think the patient satisfaction is the most important thing. I think we have not done a good job in this respect because people are rushed. I think we need to be respectful to the patient, be courteous to the patient, and more importantly, honor the patient's autonomy and make shared healthcare decisions. I am against medical paternalism. I think that is the most important thing, to be empathetic to the patient, being compassionate, because the patients are going through a lot of difficulties when they are faced with life-threatening challenges. I think the physician at that time can offer a lot of comfort. So it's very, very important, as in palliative care. I mean, you cure sometimes, you treat, but you comfort all the time. So we can offer comfort to all the patients. I think that is the most important thing when it comes to patient care.
If you had to tell one thing about learning and education for us to remember, what would that one thing?
Learning in medicine, I think the patients to me are the greatest teachers to me. I think they come with their unique and complex problem. And to me, it is fun sometimes to solve the riddle. Even though they are going through hell, I take it as a challenge and learn from that encounter. That is one core competency which has been very well described, what is called patient-based learning improvement or practice-based learning improvement. I think that is the most important thing which we need to inculcate in our residents.
And lastly, if you had to tell one thing that we should remember about cost management, what is that one thing? As we go about our rounds today, tomorrow, next week.
I mean, you should look at the value of the test you are doing. Is it going to give you a high probable diagnosis, or are you doing a test to exclude? There is less than 1% possibility of excluding the disease. I think what we don't teach well, which ACGME puts a lot of emphasis on, is called sensitivity, specificity, pre-test clinical probability, and the likelihood of that test being positive or negative. Obviously, you have to factor the cost into the equation. I think we don't do that well on a daily basis. We order testing without clinical reasoning. Why are we doing the test? What it is going to show? What is the yield of the test? What are the side effects or safety concerns of the test? I think this we need to practice on a daily basis because it doesn't come naturally and reflects to you. But if you practice on a daily basis, it becomes your second nature.
Thank you for joining us with Dr. Vasudevan. I hope that you benefited from his eagle-level awareness of the healthcare system and that you will apply some of his immediately practical suggestions for beneficial clinical practice. Please subscribe to stay updated on our newest episodes featuring the insights of top physicians, and please do comment about your experiences to keep the conversation going. Thank you again for joining us for this opportunity to learn from the masters of medicine.